You're listening to Finn Voices on Healthcare Now Radio, where we highlight and amplify the voices at the forefront of health innovation that improves people's lives. Join us for an inside look at the change makers driving conversation and answering the most important questions in healthcare today. Thanks for joining us.
Hi, everyone. Thank you for joining us on Finn Voices, a show where we amplify the voices of healthcare innovators. I am your host, Carrie Young, coming to you from the Twin Cities of Minneapolis and St. Paul. I'm a partner at Finn Partners, where I have the privilege to work with leaders across the health ecosystem. Today, I am thrilled to introduce my guest, Paul Verrastro, Chief Marketing and Strategy Officer at CVRx. Paul has over 30 years of experience in the cardiac rhythm market. Over his career, he has helped bring a number of new technologies to market, such as implantable cardiac defibrillators, cardiac resynchronization therapies, implantable loop recorders, and leadless pacing. Paul has been with CVRx since 2021, and we are excited to speak with him today about CVRx and their novel heart failure therapy device called Verrastro. You can find Paul on Twitter at PVRX, and welcome, Paul. Thank you so much for joining us.
Well, Carrie, thank you so much for having me. The pleasure is all mine. Excited to talk about this topic.
Yeah, so let's start at the beginning. I want to hear about what led you to MedTech and ultimately working at CVRx.
Well, Carrie, you mentioned in your introduction, I've been in the field for over 30 years. It's kind of closer to 35 years at this point. So hopefully my memory is good enough to take me all the way back in time. But I think I can blame and thank one person in my life who was most influential, and that's my dad. My father was a pharmacist in a small town in upstate New York, where I grew up. He would often go to his pharmacy and just people would be there for advice. I mean, he dispensed probably millions of prescriptions over a lifetime. He probably dispensed more advice than that, and somebody that I really looked up to. So when I got out of college, I was looking to kind of get into a business career, and I really wanted to enter it through the sales organization. I felt learning it from sales is the best way to really understand a product and to understand customers. And there was a lot of different businesses at the time that were really exciting. This was back in the 80s. And my father kind of really suggested that I look at healthcare. I think he really wanted me to do something that he felt could make a difference like he had. And he had a lot of respect for the people, the pharmaceutical reps. He used to call them detail men, who would come to see him and educate him on different options, for pharmaceuticals and for different prescription drugs and things like that. And his pharmacy had a number of other things, splints, braces, all kinds of different things. And he felt if I could do something like that, it would be a great way to learn the business and be something I could do that was proud of. So I really thank him. That's kind of the start of it. Now, I could say I updated my LinkedIn profile and I went to Indeed, but of course that wasn't there at the time. So I did what we did. We went to the Sunday New York Times and looked for jobs and found my first job in the Albany, New York area as kind of a small orthopedic distributorship. Got into the business that way, then went into eye lasers for about a year and a half. But the big break really came when I got into Medtronic. I was fortunate enough to get a job in the pacing industry. It was actually CRM, cardiac rhythm management. And kind of the way things work in this world, it was actually somebody by the name of Jackie Eastwood, who was an executive at Medtronic at the time. And she was very fond of my father. My father and my mother did an awful lot for her in a lifetime. She used to babysit for us. And I think as a favor to him, she got me an interview. And I joined Medtronic in 1988. And we had pacemakers at the time. And so I covered probably thousands of implants. We would go into the operating room or to the EP lab or the cath lab to help support the implants and to help follow these patients. So learned a lot about cardiac devices during that time. And then following that, the industry grew into have the first implantable defibrillators. So sort of lived through that phase. And around that time, I moved into marketing, which was kind of helping educate our customers on the options that we had, but there was also a lot of forward-looking strategy on the direction that we would go as an industry, as a company. And then we moved into cardiac resynchronization therapy that kind of got us into heart failure. So I led a number of organizations in Guidant, which later became Boston Scientific, in the cardiac rhythm management, and then kind of found my way back to Medtronic from 2010 up into 2021 when I joined CVRx.
Your bio speaks for itself. So I want to zoom out a little bit and talk about heart failure prevalence in the US? So some of our listeners might not be, as familiar with the prevalence. What is heart failure? How big of a problem is it? And what are some of the symptoms?
So a couple questions in there, Carrie. Maybe I'll kind of work through the, I can remember what is kind of the general definition of heart failure is a chronic progressive condition in which the heart is unable to supply the body with enough oxygenated blood to meet the metabolic demands of the body. So there can be a number of different reasons for this, but it is a big, big problem. It's very big in terms of prevalence and consequences. It's been called an epidemic, and for good reason. In the United States right now, it's thought to be just under 7 million patients affected by heart failure, expected to grow to about 8.5 million by 2030. So despite the fact that all the progress we're making in educating people on lifestyles and diets and exercise and everything else, we continue to see the prevalence of heart failure grow and grow. Worldwide, it's probably over 25 million, somewhere 25 to 26 million of numbers I think I remember on that one. And then we look at the economic impact. It's probably the biggest expense to the healthcare system, somewhere around $70 billion annually spent in just the US treating heart failure. So lots of opportunities for a number of different ways to help these people.
Obviously, are the different ways that heart failure is classified, right? Can you talk about, educate our listeners about some of those?
So when you think about classifying heart failure, there's a number of different dimensions. One of those could be right-sided heart failure versus left-sided heart failure. So kind of where does the heart weaken? On the left side, that's pumping out oxygenated blood to the body. So if the left-sided heart failure, that's the typical one, would be inability for the left side of the heart to pump out that oxygenated blood. You could also describe heart failure as right-sided heart failure. Right side would send the blood to the lungs to get oxygenated. So if you have the problem there, then you're not going to get enough oxygenated blood to the heart again to pump that out. So right and left side are one of the two ways. Another classification would be systolic or diastolic heart failure. Systolic, the contractile phase of the heart. And so systolic heart failure is an issue with the contraction, not contracting strongly enough to pump out enough oxygenated blood. Diastolic is a relaxation phase of the heartbeat. So it's actually a challenge of relaxation. The heart doesn't relax enough to fill up with enough oxygenated blood, and therefore it can't pump out enough oxygenated blood. Those are a couple of the different ones. And then really where it gets into a devices that we're going to be talking about is it sort of takes that systolic and diastolic and looks further into how much blood gets pumped out of the heart with each contraction from the left ventricle. And that leads to a couple of other definitions lined up to that. So the systolic, the contraction challenge for the heart failure would be something called HFrEF, heart failure with reduced ejection fraction, typically defined as about 40% of the blood gets pumped out with each contraction, 40% or less, I should say. If you looked at diastolic heart failure, then we're looking at, it still had a higher percentage, typically above 50%. But again, the heart didn't fill up with much blood to begin with. So 50% is not enough blood getting out. So we take those definitions into typically HFrEF and HFpEF, heart failure with preserved ejection fraction. Then you've got this mid-range between 40 and 50%. So a couple different ways, I think, to your answer, that heart failure can be defined.
So what are some of the main ways that heart failure is treated? What options do patients have to treat heart failure?
Yeah, I thought I learned this through my career. I actually am learning it more in my personal life as I'm getting a little bit older and more family members and friends are being diagnosed with heart failure. So I think the main one I always go back to is lifestyle. What can you do in terms of diet, exercise, compliance in all areas and things like that, in terms of improving your symptoms for heart failure, improving your heart failure condition, be number one. I think we're very fortunate that there's been a big advancement in terms of the medical therapy options. For a long time, it was drugs like beta blockers and ACE inhibitors were sort of the mainstay there. And then just recently in the last few years, there's been two big classes of heart failure drugs that have made significant improvements in the lives of these patients. So the one class is the ARNIs, drug like Entresto, and then the other is SGLT2 inhibitors. And so recently, the guidelines for treating heart failure patients were updated to the four main classes of drug treatment. So this has been a tremendous improvement. And then on top of that, you've got a number of different devices that can work synergistically with these meds or where there's a gap in care.
So talk about lifestyle changes, talk about medication. We understand there are a number of devices. why do we need another treatment option?
Well, I think our option that we're going to talk about, CVRX's Verrastro option, helps fill in some of the gaps that still remain. And there's probably still even additional gaps beyond that. I think there's still plenty of room for advancement here. But let's take a look. I mentioned that the fact that we're fortunate, or patients with heart failure and those who treat them are fortunate enough to have such great advancements in medical therapy. Now, some recent data has shown while the medical therapy, these guideline-directed medical therapy drugs of the 4 classes we talked about, have shown improvements anywhere from a year and a half up to about 6 years in terms of improvement in expected life expectancy. That's great. It's also shown improvements in helping keeping patients out of the hospital, which is also great. But what the meds have not shown in a recent meta-analysis of 29 different studies is they've shown moderate improvement in exercise capacity. Now, it's not like these patients are going to go out and run marathons and things like that. So let's talk about that a little bit. The patients are going to live longer and be out of the hospital more. What do they really want? They want to be able to do more with that time. And so when we talk about exercise capacity, kind of clinically, what that means to a patient or somebody suffering from heart failure is, can I take a shower, dry off, change, and go make breakfast without being out of breath? Can I walk down to the mailbox to check my mail? Can I take the dog out for a walk? Can I go walking with a spouse? Can I go to the grocery store and shop for myself? If people come over, family, can I join them out in the backyard, or do I have to sit on the sofa because I'm so tired? These are the things that really, really matter to the patients. And as I mentioned, the medical therapy has shown to improve their survival and keep them out of the hospital, but is not shown to improve exercise capacity. So that leads the opportunity for additional devices, or I should say for devices to complement the medical therapy. Now, in the group of patients that we're talking about, I didn't mention this in the classifications, but one of the ways you classify heart failure patients is by symptoms, New York Heart Failure Association. So we're talking about a class, say, 2 to 3 patient, okay? Not somebody who's a class 4, who's typically you're looking at a transplant or an LVAD. But in that kind of class 3, there's been a wonderful therapy that got FDA approved around 2002 called cardiac resynchronization therapy, or CRT. Some used to call it biventricular pacing. Those patients would have kind of a dysynchrony between their right and left ventricle that would result in less blood being pumped out. Cardiac resynchronization therapy was put wires on the right side, put wires on the left side. You could synchronize the heartbeat and restore that synchrony. Those have shown tremendous improvement in patients' ability to do more, that exercise capacity that we were talking about. The problem is it's a very small percentage of patients. At best, the data would say these patients that we're talking about with a reduced ejection fraction on guideline-directed medical therapy who are symptomatic, say, at class 3, only about 30% of those patients may even be indicated for cardiac resynchronization therapy. So that's the opportunity for another device. Patients on guideline-directed medical therapy getting the benefits of extended life, hospitalization, but not getting that benefit of being able to do more, and who are not eligible for the existing device therapy that's been out there for 20 years, cardiac resynchronization. And it's a lot of patients. And that's where technology like Verrastro from CVRX can be very helpful to those patients.
If you're just tuning in, you're listening to Finn Voices on Healthcare Now Radio. I'm Carrie Young, and today we're speaking with Paul Verrastro, Chief Marketing and Strategy Officer at CVRX. What you're talking about is quality of life, right? Which is so critically important. And we all probably have been touched or know someone suffering from the symptoms of heart failure. So what you're talking about really resonates with me. I want to hear more about how does Verrastro work? And then what are some of the benefits to the patient?
Yeah, that quality of life thing, Carrie, before we go into how it works, is so important to patients. And so much of the quality of life comes from what we talked about earlier, being able to do more. And so, do I feel better, the quality of life? And a lot of that is coming from, I can actually go to the grocery store and take care of myself. That improves the quality of my life. I can spend time with family. I'm not exhausted at the fact that the grandkids may come to visit me. So those two things are really intrinsically tied together. And I'll talk about some of the data on that one. But Verrastro takes a different approach. And so you mentioned 30 years of my career. And as we looked at these heart failure patients, as we were moving more into it, it kept becoming more wires in the heart, keep going at the end organ. Something wasn't working. Let's put more wires in the heart. Let's try to fix it. This little company in Minneapolis, CVRX, was taking a little bit different approach. They were saying, rather than treat the end thing, the heart, let's go to the very beginning, sensors. What's the signals picking up in the body? And so I want to take you back through a little bit. Part of in heart failure, one of the big characteristics of the patients is something called kind of an imbalance in the autonomic nervous system. Now, the autonomic nervous system has two. I'm going to put you back in your high school biology class here, Carrie. The sympathetic limb, and there's a parasympathetic. Sympathetic is known as fight or flight. That's that I got chased by a dog. All of a sudden, I just get in this high elevated state. It's a survival thing. It's that fight or flight, and things kind of happen. You're going to get into this high rev mode. Parasympathetic is rest and digest. And you need that balance between both, and both have served the purpose at the right time. In heart failure patients, they tend to have elevated sympathetic tone and decreased parasympathetic tone. They tend to be in that fight or flight state the whole time. It's like the car engine is racing all the time on a car. You come to the stop sign, you put in your garage, the engine's always racing. That's not good for the engine, not good for the heart. Well, one of the mainstays in treating heart failure patients has been, medical therapy to try to adjust sympathetic, parasympathetic tone, or device therapy. So if you look and say, if a patient's in an elevated sympathetic tone, what's happening? It can be the increased heart rate, it could be increased blood pressure, it can be decreased function in the kidneys, a whole bunch of things that are not good for heart failure. So you're looking and saying, is there any ways you can rebalance that? Can you decrease that sympathetic tone and increase parasympathetic, decrease that fight or flight, increase rest or digest? That's a goal that anybody who's treating heart failure understands. So that's what this is trying to do, rather than just control the heartbeats. So now you got to figure, well, if you're trying to decrease sympathetic and increase parasympathetic tone, how can you do that? Well, there's a wonderful system in the body. The body has so many different sensors. One is a pressure sensor. And one of the sensors sits right on the carotid artery. So every time the blood comes through the carotid artery, that artery stretches out a little bit. This sensor, called the carotid baroreceptor, sits on the outside of that carotid artery. Each time blood flows through and the artery stretches, the baroreceptor stretches, that sends a signal to the brain. So the brain is constantly getting this input about blood flow and pressure and making adjustments to sympathetic and parasympathetic tone. So, for instance, if you had low blood pressure, if that receptor sensed low blood pressure, the brain would sense that and say, well, I want to increase sympathetic tone. I want to increase the heart rate. I want to increase the constriction. I want to increase the blood pressure. If you had higher blood pressure, the brain would do the opposite. It would say, I better be careful here because I got the high blood pressure. Let's slow the heart rate down a little bit. Let's vasodilate to lower the blood pressure. Let's take these actions on the things. So this was a very clever approach that CVRX took, which is the company. I've been watching them for about 20 years. What they figured out is, what if in a heart failure patient, what if this baroreflex has become less responsive, less sensitive? In other words, that signal to the brain kind of thinks that the blood pressure is lower than it should be. Well, if that blood pressure is lower than it should be, it's going to cause the body to elevate sympathetic tone. So CVRX figured, well, what if we did chronic or constant electrical stimulation to the carotid baroreceptor, high frequency, consistent electrical stimulation to the carotid baroreceptor? That would mimic pressure, additional pressure. The baroreceptor would signal the brain. The brain now would interpret that to mean, well, there must be a little bit higher blood pressure. I ought to take appropriate corrective action, decrease sympathetic tone, and increase parasympathetic tone, which is the goal of treating heart failure patients. So it's a very novel approach. And what's really interesting about it is, rather than trying to treat the heart, it just sends a signal to the brain, corrects the signal to the brain, restores the electrical signal to the brain, lets the brain do everything else from there. That's why we kind of refer to our tagline is outsmart the heart. I go back 30 years, cardiac devices go back to the 1950s. The brain has been managing the heart for millions of years, knows a lot more how to do this than we'll ever know. And so when I say we, I'm talking about CVRX, well before my time, just figured this really elegant approach. Stimulate that carotid baroreceptor, let the baroreceptor see that as additional pressure, signal to the brain, let the brain interpret that as a higher blood pressure, and then decrease sympathetic and increase parasympathetic tone, exactly what you're looking to do. And it's had tremendous benefits in heart failure patients.
So what are the heart failure patients most likely to benefit? Who's a good candidate?
Yeah, so I think one of the really responsible things, and I give so much credit to the team who was at CVRX before me, I think they really tried to identify who's the group of patients most likely to benefit. So if the device went into those patients, they're most likely to receive the benefit. They weren't trying to maximize the number of patients that we could sell to. And so they're very cautious and very specific about the indication, which you have to be in a clinical trial. It was a patient with a reduced ejection fraction, that half-rep patient, and they defined it as 35% or less. So you got a patient who's 35% or less with a class 3 New York Heart Failure Association class 3 indication, or a class 2 with a recent class 3, who remains symptomatic despite being on the best medical therapy or guideline-directed medical therapy. Now, for those listening, there are two others. Defined it as an NT-proBNP, which is kind of a biomarker for the condition of heart failure of less than 1,600, and patients who were not eligible for cardiac resynchronization therapy. And as I mentioned, a small percentage of those are. So if those patients were indicated for CRT or cardiac resynchronization therapy, that's a frontline therapy, and we felt that those patients deserve that.
So walk us through the actual procedure and recovery process. What's it like for the patient?
It's actually I would say a fairly simple surgery, although I've never performed surgery. Basically, any physician who does a carotid endarterectomy, which is a small incision in the neck, and they go and kind of clean out plaque in the carotid artery. Basically, it starts like that. It's a small incision in the neck. Okay, the physician then identifies the carotid artery. They're not putting anything inside the artery. It's just simply suturing an electrode to the top of that carotid artery. Okay, right where those carotid baroreceptors are. There may be some testing to see if we see a change in blood pressure or heart rate. And then there's what they call a pocket made in the upper chest, typical of a pacemaker or defibrillator where you put the device in. The lead is tunneled under the skin over the collarbone into the device, put in usually about 45 minutes to an hour or so in terms of a procedure. Patient typically goes home the same day. So in many ways, very much like a pacemaker or defibrillator in terms of the total procedure.
Okay, and what's the recovery process like? It sounds reasonably, I'm going to say simple, though the technology is complex.
Yeah, I mean, anytime you have a surgical procedure, you're always looking, to make sure the wound heals appropriately and all that. But with pacemakers and defibrillators, you have wires going down into the heart, and there's often this arm restriction. You don't want people moving their arm. We don't have any of that. So generally, patients get back to full activity within a few weeks, always under the guidance of their physician. They should go back to. But anecdotally, I've talked to a lot of patients who have had a pacemaker or an implantable defibrillator sometime in their life, and they've said this is actually kind of easier to make.
Interesting. So I'm guessing that patients are always curious about how long it is before they can get back to their normal activities, right? Walking the dog, picking up the mail, playing with the grandkids. How long does it take for patients to feel the benefits?
So we've heard anything. I mean, some patients will report getting benefits almost immediately. We've had patients in the hospital telling us that. Okay. Some patients will talk about, I was in a wheelchair getting into the hospital. I was able to walk out to the car and we've had that. Now, more likely it's somewhere in that 2 to 3 month range, because what's going to happen is after the implant, there's going to be kind of a steady increase to the amount of current or electricity as we dial that up post-surgical. And it's usually done over, say, 4 or 5 visits over the first 2 or 3 months. But usually in that somewhere up to 3 months range. It can be varied. And I do want to talk about some of the benefits, Carrie, that they're actually feeling, if I could. There's a lot of anecdotal, but I also feel that the company did a very responsible job of generating, very credible clinical evidence. And the evidence you really want is a randomized clinical trial. So what the trial was, BEAT-HF, which was the pivotal trial, started in 2016. Patients were on guideline-directed medical therapy. They were titrated. They were stable for at least a month. They're already getting some benefits. Now the question is, what happens? What would Verrastro do? So the trial took and split the 2 patients. One group of patients stayed on guideline-directed medical therapy. The other group of patients stayed on guideline-directed medical therapy and got a Verrastro implant. I'll characterize it as, the way I look at it, as the group of patients who are on guideline-directed medical therapy, which would be the control group, generally stayed pretty stable, which is a good thing for heart failure because it's a progressive disease. The patients with Verrastro got turbocharged, the way I think about it. not only were they just stable, we saw huge increases in terms of what they could do and how they could feel. So one of the standard tests for exercise capacity is a 6-minute hall walk. How far could people walk in 6 minutes? And you compare that, the group that got Verrastro versus the group that stayed on guideline-directed medical therapy, the difference in improvement was 60 meters. For those unfamiliar with the metric system, that's about 2/3 of a football field. That's 6 minutes. So you think you're walking, holding somebody's hand, and 6 minutes later, you're that far ahead from the person. That person's stopping, catching their breath, doing all those things. That 60 meters is what we talked about earlier. I feel that I could go to the store. I feel that I could go and take a shower today. I feel that I could go upstairs, right? That's what it really means. That's 60 meters. And when I think back in my career, there was some landmark trials for biventricular pacing or cardiac resynchronization therapy, trials like Contact CD or Miracle. The benefit was about 30 to 40 meters. What Verrastro showed was an improvement that was almost double what we saw in these big landmark cardiac resynchronization therapies. Double, despite the fact that the control group is on such better medications today than they were 20 years ago. That was mind-blowing to me. I was at Medtronic studying this and kind of watching all these companies. And I thought it was a typo.
And we're gonna have to leave it there, Paul. I mean, that's amazing when we talk about quality of life, and that's what you're talking about, right? Like really making a difference for patients. So as we wrap up here, what's ahead for CVRx?
Well, biggest news is just getting the word out to more and more people. I mean, a lot of people in therapy. So we've been kind of expanding our field organization rapidly to try to get to more people to understand it, getting into new centers. We anticipate, extending data or providing additional data to what we saw in the BDHF, which also showed a quality of life improvement, 25% reduction in NT-proBNP. We expect to have additional data to that. And we'll continue to keep feedback and kind of getting out more and more programs as we look at different ways of either advancing technology over time into different directions for new patient indications or new patient populations we could study, or maybe enhancements to the technology. So lots to do here. We've got to come a long way, and we're really excited about all the things we can do in the future as well.
Well, let's leave it there. And I'm going to direct our listeners to cvrx.com. And also, if you want to follow Paul, he's at PVRX on Twitter. And Paul, thanks for being with us today. To our listeners, thank you for listening to Fin Voices, a show where we amplify the voices of healthcare innovators. I'm Carrie Young with Fin Partners, and we'll see you next time.
Fin Voices is brought to you by Fin Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact on the world around us. Learn more at finpartners.com and follow us on Twitter @FinPartners.